membranes have been used Yep. Amniotic membranes have been used clinically since the early 1900s. It's a barrier. It reduces inflammation. It helps reduce scar formation. It's immunologically privileged tissue. In other words, just how mommy doesn't reject the baby, because they're not the same person, we're not going to reject this tissue. So it's not something like we have to match like a kidney or a liver or a spleen or whatever else you transplant. This is actually, it wouldn't be transplanting a spleen, but anyway, this is stuff that you don't have to worry about rejection. You don't have to match the person. What does it contain? It contains growth factors and extracellular membrane, which is a collagen background. We'll go a little more into that. So I'm just trying to minimize. Okay. So this is usually done from a full-term C-section. For most of the donor banks in our country, they check the mommy and baby for the following stuff that you see there: HIV, syphilis, hepatitis. And they usually check also on the mom and baby that they're healthy 6 months later while this is being processed to get it from the placenta to the processing plant to the box that is delivered into you. It is screened and usually treated with antibiotics or sterilely manipulated as far as gamma irradiation or something like that to make sure it has no really usually live cells or microbiology. Now, some sources of allograft amniotic membrane do have live cells. I'll talk about that in a little while. So far, everybody with me? All right, good. That's what I like to hear. All right. So,
yes, sir.
Again, first reported use 1910, used in the mid to late 1900s, much more commonly. They used to literally take it right from the placenta of the mom and throw it on a wound, and it did great. Then the 1980s came, and HIV and I'm sorry, just skipped ahead there a little bit. Other diseases came about that we realized that we could be transferring disease, mainly viruses like this, and we had to start doing the transfer in a different way. So now these things are processed. We don't just take amniotic tissue or placenta and rinse it off in the water and just throw it on somebody. It's used in ophthalmology a lot. And one of the things we don't want in ophthalmology is an inflammation reaction and growth of angiogenesis. It's kind of what we do want in wounds. So it's been processed and treated differently. Up about 2000, we started discovering, hey, this stuff could be used really well for wounds, but we have to go through a process to sterilize it and make sure we're not passing along any infections. There's a couple of different classes of tissue. I think it's important to talk about it. The 361 HCTPs, that's allograft. It's minimally manipulated and intended for homologous use. That's really what this is. So it's not really manipulated much, and it's considered for homologous use. What does that mean? It's a covering. Just like this was a covering for the baby, this is a covering for a wound. So that's what this is considered. That's how you should market it. That's what we could say it is. We don't want to call this a skin graft. We don't want to call this anything it's not. We want to call this human tissue that's been minimally manipulated, basically to get rid of any virus or anything else that's there, and then packaged so it has a shelf life and used for homologous use to cover a wound, just like it was to cover a baby before. Then there's other devices or different classification. Let's say, for instance, a PMA, a pre-market approval. That's your appligraph or dermagraft. That's human skin that needs to be studied. That's human skin growing in a bovine collagen that needs to be studied. It requires FDA pre-market approval with clinical studies. Whereas what I was just saying before, the human tissue allograft does not. You could say that's good because we don't have to have any studies. You could say that's bad because it wasn't proven to do anything. And we're not claiming it does anything. It's a covering. We do know it does things, and I'll talk about that with you in a little while. Then there are other classifications of 510. That's your xenografts. That's your pure apply. That's your bovine, your collagen. That's your pig skin, your cow skin, anything like that. That really, when I say skin, it's collagen. Those have a different process as well. They just have to say that it's safe and effective. It doesn't have to be FDA approved. Okay, so we talked about this already, that it's amnion is considered immune privileged tissue. Class 2 antigens are not expressed. This has been extensively studied and been used safely for years. So there's never a question of rejection on an amniotic membrane. This big thing on the left is the whole placenta area, right? With the baby in the middle here. This is the amniotic sac. What we're looking at here is just a little cross section, like let's say right here. This is the layers right here, the amnion and the chorion. That's this section, just this little section right here, or let's say right here. Okay, so this is what it looks like under a microscope. There's our baby. The layers of the skin are the epithelial layer over here. Then you have a basement membrane. Here's the amnion, and then here comes the chorion. So just to give you some cell layers. I don't want to get too deep into the cell layers here. I'll tell you what I think is important about it in a minute. Yet another look. You got your amniotic fluid up here. Then you got your amnion here and your chorion here. And you can see the amnion's a pretty thick layer. Then you got another layer called the spongy layer that's in between the amnion and the chorion. And then you got this chorion. They all contain collagen and extracellular matrix. They all contain growth factors. That's really the important thing about them. I don't think you have to memorize what type of collagen is found there. It's not important as far as wound healing goes. And we'll talk about the growth factors in a minute. This is a list. It's not inclusive, and it's not on every amniotic membrane, but this is a list of over 200 growth factors, or I like to call them bioactive peptides, that are found in most amnion and or chorion products. It might not be everything here, might not be in each amnion chorion that we know on the market, and there might be some that aren't here that are in them. But this is just a list. Like, it's an amazing list of things that are bioactive that are found in amniotic membranes. Some of them are inflammatory, some of them are anti-inflammatory, some of them inhibit growth, some of them ignite growth, some of them are angiogenesis, creating blood vessels, and others are opposite. And they all work in a chemistry together. There's not one that stands out that is needed and the other ones aren't. And they're all, we don't really know the right cocktail or what strength or dilution, which ones are needed, which ones are not needed to help wounds heal. We just know they're all involved. Just an example of amnion and chorion, of different growth factors that are commonly known in wound healing. So the things on the bottom are the different wound healing, like platelet-derived growth factor, AA and BB, VEGF, and different insulin-like proteins, and different other factors here. Where they're found in the amnion and chorion. It's just an example. Remember, there are over 200 of these. Here's only about 10. Just giving you some examples. So if someone says, I have an amnion chorion or I have an amnion only, that's great. We don't know which mix helps heal wounds. We just know they all contain collagen. They all contain growth factors. And these growth factors in collagen have been proven to help heal wounds, especially stalled wounds that have either biofilm or just lacking growth factors. So it's bringing growth factors to start the healing process. So how do I decide which placental product to use? So like I was saying, we don't really know what combination and what concentrations these things need to be for ideal wound healing. We just know that it seems to work, that when you put on amnion or chorion or amnion chorion or a spongy layer, they help heal wounds. We're kind of selling this or promoting this as a wound covering or a barrier. It just happens to contain growth factors and anti-inflammatory and inflammatory products that stimulate wound healing. That's how you should describe it when somebody asks you, what is this? What are we using it for? Now, some of the stuff is not, we don't use it for, the indications aren't there for Medicare, but it could be used for wounds, tendons, ligaments, bone. It could be injected. It could be made into a sheet. What you're doing is you're providing growth factors and other active peptides and collagen or an extracellular matrix. That's what you are doing. These are all some more of the growth factors. So if any of your, doctors out there or you guys, if anyone asks you, well, like, what's in here? Well, here are some examples of what's in here. And this is what they do. We know that they are important mediators in wound healing. This has been studied extensively. We don't know which concentration or which ones come in first or second and what needs to be done in what order. It's a harmony. It's a dance of all these factors that help heal wounds. But you could tell someone, well, here are some of the factors that we know are in amnion and or chorion. Then there are cells. They're fibroblasts, cytokines, chemokines, interleukins, macrophages, mast cells. All these are contributors to healing wounds. And most of these products don't have live cells, and I'll go over that in a little bit. Dehydrated amniotic chorionic membrane. There's some studies of healing peroneal tendons and scarring. We're not using that much for the purposes of the list. This lecture is mostly on diabetic foot and venous leg ulcers, but these things can be used in tendon and ligament repair as well. Plantar fasciitis, they can be injected. Again, I know this is not the specialty of most of the docs that are going out there, but there's been studies done on injecting this in plantar fasciitis when you want a steroid-free mechanism to try to get things better. I'm not sure we have this available in injectable form, and some states it's not legal. I'm just throwing it out there to be complete in this lecture. This is when it was done on a partial thickness patella tendon. I'm not going to spend too much time on this because I think the focus should be on wounds here. And we're going to go away from the musculoskeletal. We're just going to go to a case or two and then talk about another thing or two, and I want some questions. This is a venous leg ulcer on a 54-year-old female. 4-month history, it was not getting better. I was doing compression. I was debriding it weekly. No change in size over 6 weeks. So keep in mind, by the way, if you don't debride a wound and provide compression on a venous leg ulcer, I don't care what you put on them, they're never getting better. You must do the basics of wound care. You must keep on a diabetic foot. They have to have their sugar under control and offload. You're not going to put something on them and them magically heal. You have to debride. You have to have a clean wound. It can't be infected. You have to offload it. Those are all keys. A doctor can't take this and put it on a necrotic wound and think it's going to heal. That wound's got to be debrided to bleeding level before applying it. All wounds every week. I applied on this woman an amnion chorion. You might be able to see it in the picture. There's a little like filmy layer over it. Then an Uniboot. It was a competitor's, but this was done many years ago before Amnio Armor was out. After application 2, after application 3, you can see it getting a little more red and granular. After application 4, and then finally, I think after the 5th or 6th application, the patient was healed. Then you have to put them in compression stockings forever. Otherwise, this is going to open right back up again. So, you're not done when the wound's healed. Just the patient is done with the wound, and their chance of infection goes down dramatically. Here's another case of a diabetic foot ulcer on a big toe. Patient had an angioplasty. They were offloading in a shoe. Nothing worked. In all honesty, I took the patient to the operating room and performed an arthroplasty, then put on 3 amniotic membranes. The thing healed in weeks. It was probably going to heal anyway, but instead of healing in 6 to 8 weeks, it healed in 3 to 6 weeks because of the use of amniotic membranes. The patient was full weight bearing the entire time. What was it? Hello? I'm sorry, I couldn't hear the question. Okay, I'm going to go on unless someone has a question. This was an 81-year old male with a peripheral arterial disease with a heel ulcer. And I put this one in here because the ABI was only 0.59. Now, my vascular surgeons wanted to revascularize this patient, but they wouldn't consent. So I told him, I don't think you're going to heal, but we could try anyway. So I debrided him. I used collagenase for a couple of weeks and got rid of the eschar. Then I kept doing that until the eschar was gone. And then it started to become a little fibrotic and some patches of red. After I got some red, it got granular. And then I started using amniotic membrane because it was shrinking in size now. So I applied amniotic membrane weekly, 8 grafts. It took a lot. Didn't happen overnight. This guy's got very poor blood supply. But in the face of poor blood supply, this healed anyway, because we're delivering the growth factors that are potentially missing from this wound that he can't deliver for himself. And then he went on to heal. I just contrast a couple of things out there just so you know what's in these grafts and what's not. It doesn't make one graft better or worse than the other, but Amnio Armor and RevaShield or Amnion. EpiFix is amnion, chorion, and epithelium. New Shield has all. Biovance, as you can see there, has some of the contents, and the rest of the list is pretty self-explanatory. The preservation methods are different on some of these grafts. Amnio Armor and Revagen are dehydration. Some of them are cryopreserved. Some of these are stored in a freezer. Some of them are stored in a refrigerator. Our product here, Amnio Armor and RevaShield, is dry and stored on a shelf at room temperature. The advantage of that is that it has a shelf life of a couple of years, and you don't have to order it ahead of time for your patient. You could just store it in your office, and you don't have to waste storage space on a refrigerator or freezer. So it has a lot of advantages. And if your patient doesn't show up, your graft doesn't die in a couple of days. So there's a lot of advantages to having a dehydrated room temperature storage of a graft. Some of these grafts have live cells, and there's some right there, Graphics and Affinity. Now, why is that good? Well, that's nice because live cells lay down growth factors. The truth is they're dead in anywhere from 3 to 10 days, and you'd have to put on another one. So it's not like they're living and then they stay alive in your patient. These cells die eventually. It's nice to have them. I don't know if it's good or bad as far as will it heal a wound. I just know that it helps deliver growth factors, which we are delivering without live cells as well. Then, of course, we got to get paid. I think a lot of you were at the kind of billing and coding for the this kind of meeting, but basically there's a Q code. You have to bill for the Q code. You have to bill for the application of the graft, and you have to link that with the appropriate diagnosis code. I always like to have 2 diagnosis codes. One is the etiology, the other the location, and then the application code, and then the Q code for the graft. Here's the CPT codes for application. We usually use 15271 on the legs, 15275 on the feet. Then you got to go by how many units you're putting on, and that's just a square centimeters, and that's your Q code. Just some examples. A venous leg ulcer, there's some codes. Diabetic foot ulcer, there's some codes. And then there's the application code with a modifier right or left. That 25981 is an Uniboot. Then you put the amount of units of the Q code you used, and the amount wasted is JW. You're still going to get paid for the full amount you purchased, even if you document that you wasted it. Every local LCD, in other words, every local Medicare carrier has its own little tips and pearls. If anyone has any questions, I'd be happy to go over it with them or any providers out there. That's a quickie on wound care and amniotic membranes. I know I went a little fast because it's a little bit redundant. I just want you to know some properties of these amniotic membranes, what sets them apart, storage, and how they're processed. Anybody have any questions on anything? Tim, I don't know if you're still on. I don't know if you had any questions or want to throw anything in. Any providers on the call?
Dr. Doolan, I have a question.
Yeah.
Regarding the graft replacement with the wound vac. Have you used it with a wound vac frequently or infrequently?
So very infrequently. I usually put these on in the office, not in the operating room. And getting reimbursed for wound vacs in the office is not the easiest thing. Wound vacs tend to create a lot of liquid drainage, and they get very macerated. So I find them that I often would, if the few instances where I've seen them applied with wound vacs, they tend to need to be changed right away.
Okay.
So it's not something I do. And remember, when you're talking about amniotic membranes, we need a clean granular base to apply this. Otherwise, you're not really applying at the right time. You're better off using collagenase and debridement until you get a clean granular base that's like red and beefy, ready to go. Maybe you have to take them into the OR to do a sharp debridement or like, a mechanical debridement with like a Versajet or something like that. But I traditionally do not combine them with vacs.
Okay.
Good question, though. Definitely put an Uniboot over these if you, if it's a venous leg ulcer or a Pro4 or some sort of compression. You can't just put a graft on. As far as documentation goes, you should always secure them with steri strips and document that you did. The documentation is a whole nother lecture. I've gone over it before, but I'd be happy to, just fill everyone in. Just make sure that you document the etiology, the amount of time that it's been there, what conservative measures have been tried, that their sugar is under control and the circulation is adequate, or at least documented. And it was an attempt has been made to revascularize them if it wasn't adequate. But those are all important things. Anything else?
Yes, this is Suzanne from Minneapolis.
Hey.
This is really helpful. Thank you so much for this. I've run across some of the new electrospun technology. Can you talk a little bit about that and the advantages, obviously, of a live tissue? You've done a great job of overviewing, but could use some help.
Yeah. So which tissues were you talking about? The new ones?
The electrospun, so they're a fiber, but they're a micro spun kind of technology, new on the market.
Yeah. So I don't use them. They're a sponge, correct?
They're like a fiber, but it's all man-made.
Yeah. So there are a couple of those on the market now, some synthetic grafts that are called temporizing agents.
Okay.
One of them that I use is called Polynova. I don't know if you're familiar with it.
Yeah, that's one of them I'm familiar with. I hired someone who had that background.
So I will tell you the difference because it's kind of like apples and oranges. So if I got a wound with exposed bone and tendon, and it's like not a great looking wound, or it's necrotic tissue, and I got to go in and clean it up in the operating room, I'm going to put something. I'm not going to put an amniotic membrane on it. I'm going to put an Integra or a Polynovo. Nowadays, I'm probably putting a Polynovo or some other temporizing agent. 3 weeks later, I'll take out the stitches, really the staples, and I'll see if there's been any granulation tissue that formed over the bone or tendon. Then I'll take off the silicone layer or whatever else is still adhered to the wound. It might even take another week or two. Then we usually have a nice clean granular base. That's when I come in with the amniotic membrane and start grafting weekly.
Okay. And do you have to do
one is to get you to the place where you can be grafted. Just like I would never use a amniotic membrane over bone or tendon and think it's going to be the answer. I would never use one of these temporizing agents over a good granular clean wound. It would actually delay your healing. Once it's granular and clean and red and beefy, it's ready for amniotic membrane growth factors. And then putting on those other things just kind of makes it stagnant. You could even become hypergranular.
Okay. Thank you.
Yeah, no problem. Anybody else? Anything else? I mean, these are good questions and they're real life. And, you know, a lot of times you'll be saying to one of your docs, like, well, I wonder why they're using an Integra today and they didn't ask me to put them in there, because that's how it is in the OR. And guess what? They'll never use an Integra or a Polynovo in the office. One, it can't be billed for and be reimbursed. And two, that patient is probably not a good candidate for an office procedure because they need something more. So those are very good questions. I can't argue why you should use this over like an Aplograph or why you should use an Aplograph over this. They both contain growth factors. They're both maybe needed in your armory because sometimes the insurance just doesn't work for one or the other. If you have an arterial wound, you can't use Aplograph. If you have a post-op wound dehiscence on a non-diabetic with no venous leg ulcer, you're not allowed to use Aplograph. Period. End of sentence. They need to be diabetic or venous leg ulcer. However, if you have a diabetic that has a Medicare HMO, that might be your only option, even if you like this stuff better, just because it might not be approved. So there's like a lot of potential competitors, but everyone's got their own niche. And once you know this niche, I think you could push towards filling the niche. And the niche here is definitely any kind of wound. There are no exceptions. Anywhere on the body. And Medicare is your primary, is a good guideline. And then usually the secondary, you'll have to check with them if they cover it or not. But even without it, it's usually a logistically beneficial and monetarily beneficial to use this graft. Yeah, multi-layer compression and Uniboot. Have you tried total contact casting? Absolutely tried total contact casting, and I recommend it highly. And the problem comes in is, can you bill it with both? I have, and I don't always get paid. So that question's from Ruben. It's a great question. Total contact casting has its own Q code and its own application code. You're going to get paid on the application code no matter what. Grafting has its own Q code and its own application code. You're going to get paid on the application code. And what you want to do is make sure you get paid on the Q code for the graft more than the total contact cast. Even though if you get paid on both, it'd be much better. But the graft code is in the thousands of dollars, and the Q code for a total contact cast is about $150. So we want to get paid on both. It's an excellent mechanism to heal patients, total contact casting, and you usually will get paid on both. And if you don't, I would appeal it because you did both and you paid for both. But don't be surprised if certain Medicare carriers kick it back and put you into an audit and make you submit invoices and things like that because you have two Q codes on one visit. Great question.
Hi, Dr. Doolan. This is Megan Villers. Just had a quick question with the steri strips. Would that also be used for a Mohs procedure, or would that be more for the wound care?
You say for Mohs?
Mm-hmm.
Yeah. So no matter what you're using the graft for, and as you probably know, since you mentioned it, this is great after Mohs surgery. Now, the plastic surgeon or dermatologist or general surgeon, whoever's doing it, it's going to have their own opinion on how this should be fixated. If you have input, recommend that it should be fixated with steri strips. Let them do what they do, but the documentation needs some sort of documentation that says the graft was fixated. Some people throw a suture. I don't recommend it because it's like paper thin. It's like tissue paper. Some people staple it. For these amniotic membrane grafts, they're too paper thin. Some people put steri strips. That's what I recommend. Other people will just put an adaptic and a dressing, but some sort of adhesive or something I would like to see in the documentation for the surgeon's sake, in case it gets audited and they need to read your notes. But it's going to be surgeon's preference. Really good questions. Especially the Mohs questions, great too, because I don't know how many of you see plastics or derm that do face or neck or anything, but these heal Mohs scars, even on the leg. By the way, if you ever see a Mohs scar after and it turns into a wound and they can't heal it on the leg and the doctor can't figure it out, it's because the patient has venous stasis and it's undiagnosed and not so obvious. they need compression and elevation. And then along with the graft, these things do great.
And additionally, a piggyback question on that. So, say that the graft is placed, and like, I mean, it goes through all the testing to make sure that there's no pathogens, and it goes through the standard like testing to make sure that there's no bacterial growth, and that there's a culture done. In the event of some type of infection of the allograft, what are the steps that are taken to address this? In the
Yeah.
event of
Right.
infection?
So I'm going to make a blanket statement, but take it with a tiny bit of salt. There's been millions of amniotic membrane grafts applied in this country. To my knowledge, there's never been a graft-associated infection so far. Now, has a patient gotten an infection after having a graft on? Absolutely, hundreds, thousands of times. So the first step to do is try to clean the wound and debride it. Remove the graft and all debris from the wound. Sharp debride to bone, and if it's worth culturing, get a culture. Initiate systemic antibiotic or antimicrobial therapy, orally or IV if it's raging, orally if it's a localized cellulitis. Then you could also try additionally topical antimicrobial agents such as betadine, silver, or there's a million other antimicrobial agents. They're not as important as the systemic if there's a true infection. Vash and saline are definitely things I would use. Vash kills everything on contact, basically, and I would definitely use that in conjunction with debridement. You could also use a pulse lavage. The key, though, is get the graft off. Get all the tissue gone with sharp debridement to good bleeding tissue. Don't leave the graft on and say, oh, it's a barrier and has antimicrobial properties, or, oh, we just put it on yesterday. It's a waste of a graft. No. If they're infected, graft off. You deal with it when they're not infected. Very good question. And I definitely like Vash or saline. They both are not supposed to be cytotoxic. Vash probably has a little bit of cytotoxicity compared to saline. Vash has a broader spectrum of antimicrobial activity compared to saline.
Thank you.
Oh, I forgot to mention, the week before you apply one of these grafts, you could encourage your surgeon to bill a 15004 code, which is preparation of wound bed with anticipation we're grafting next week. It's a much more highly reimbursed code than debridement of wound.
Can you repeat that, please?
Yeah. Preparation of wound bed a week before applying a graft. 15004 is the code. Let me just double check that real quick. I think I got it right. CPT 15004. Oh wait, 154. CPT prep of wound bed. You have 15002, 15003, or 15004. I usually use the 4 code. Also, another thing that patients will report after getting, if they have a painful venous leg ulcer, about a day after applying the graft, they'll say that their pain decreased. There was a study done, and I think 75% of patients found a decrease in pain. Now, diabetic foot patients don't have pain, but venous leg ulcer patients do. Just one other little thing that if you're talking to, one of the providers and you're discussing, oh, this patient's in so much pain when I debride them. Okay, do the best you can. This should make them feel better. Encourage them to debride them again next visit. Don't ever leave a graft on because it looked good next visit. Always remove everything and apply a new graft. And debride, of course. Anything else?
And a final thing is if you go beyond like the average, I think it's like 6 to 8 applications that are usually
Yeah.
Medicare. Like, what if it's not even responding then?
Right.
What do you
There's
do
two things you could do then. Oh, if it's not responding or it's just not enough.
if it's not enough?
Okay. Not enough, but it is getting smaller. Document that it's getting smaller. And also, of course, have the measurements every time so we could prove it's getting smaller. Even better, take pictures. If you know that your terminal number is 6 or 8 and you know it's going to take 12, you could do a graft holiday and you skip a week. This way you save it for the following week, but still do proper wound care, debridement, elevation, offloading, all that kind of stuff. Some carriers will let you continue care until closure if you're documenting improvement every visit. If it's stagnant or doesn't improve and you keep grafting, they'll audit you. They can want your money back. But some of them have a number and they stop at the number and there's little you can do. Just make sure that if you're going to do more, that you have a carrier that is playing ball with you and they will justify it as long as you justify that the wound is getting smaller. Or consider the graft holiday where you you have 6, that's all you're getting. Do it every other week instead of every week. But do see the patient every week and debride and do wound care. Another good question. Logistics and real life are just very important with this stuff. Just as important as the science and everything. It's got to be able to get to the patient, and the doctor has got to be paid. Anything else? All right, Tim, if you're hearing me, I think I'm gonna say that we're gonna wrap up here. I thank all of you for coming. If you have any questions, get them to Tim. You could email me. Otherwise, maybe we'll be doing another little pep talk in a couple of weeks or months. You guys have a great night.
Thank you.
Thank you.
Thank you.
Thank you.
Thanks again.